Good afternoon to our Facebook Live. I'm Joanne Conroy, the CEO of Dartmouth Hitchcock and Dartmouth Hitchcock Health. And today I'm joined by the CEO of the Visiting Nurse and Hospice Association of New Hampshire and Vermont, Johanna Beliveau, and her head of quality and compliance, Sara Simeone. So happy St. Patrick's Day to both of you. I know we figured out that I'm probably the only one here that has a significant component of my heritage being Irish, but you know, we can all keep our fingers crossed for the kind of the luck of the Irish today.
Absolutely.
Anyway, we're here to talk about kind of the career path of both of our leaders here, leaders at the Visiting Nurse Association, but also to really talk about how their daily lives and the lives of their employees have changed with the presence of COVID-19 in the Upper Valley. Remember that visiting nurses actually care for patients in their homes. When we portray visiting nurses on our strategic plan, it was really important that we're in their cars because they are in their cars more than they are actually sitting at their desk. And they spend the vast majority of their time in patients' home. They're kind of on the front line for, number one, caring for patients in their homes and in the community, but number two, to really answer questions that many patients have about COVID-19 and specifically the elderly patients that they care for. So let me start with Johanna. So talk a little bit about your career, because you've been really spent a lot of time in many aspects of the health system.
I have. So I was very fortunate to join Dartmouth Hitchcock Health, and I came here first to the medical center and worked in the quality and safety department. I spent a few years of my career focusing on that part of my professional role, and had an opportunity to progress into the nursing administration. So really got to know this community here in Lebanon, the inpatient teams and the ambulatory clinics within Dartmouth Hitchcock Medical Center. And then I was fortunate to have a chance to work down at Mount Scottney, so one of our critical access hospitals, which really showed me how our communities come together, our local hospitals work in a smaller community, and I learned a lot there. And then, as we know now, I'm at the VNH as the CEO, and that felt a little bit like coming home. I had started my career as a hospice nurse, and so when that opportunity presented itself to take on a leadership role with VNH, I felt like it was the best next step for me in my career. And having worked in the medical center and at Mount Scottney and now at VNH, I really have a unique perspective on the care delivery system and all the opportunities we have to reach patients.
Well, you've done a fabulous job. I had the opportunity to be at your service awards, and the morale and the commitment of the team that you are supporting there is really incredible. And I know it's been improving every single month under your leadership, so thank you.
Thank you.
So Sara, talk a little bit about your journey.
Yes, so I started my career as a nurse at Dartmouth Hitchcock and have worked in multiple different settings within the academic medical center, and then had the great opportunity to actually participate in the Value Institute and the performance improvement training done there, which really is what launched where I am now in terms of thinking about quality, compliance, how we do process improvement. And I had done that work in the cancer center and then had the opportunity to join the visiting nurses, and thinking about being able to take what I'd learned in the academic medical center and transfer it to one of the member organizations was very exciting. And so I've been there now for about a year and we've had a great year of doing some wonderful building together.
You have, and it kind of shows in your engagement as well as really the commitment of both the individuals in the community that use your services as well as your employees. Now, COVID-19,
Yes.
it is, everybody feels like they're probably on the front line. You're on the front line in a very different way than we are here at the facility. You know, we're thinking about testing, we're trying to anticipate what could happen 2 months from now, what could happen 2 weeks from now, trying to make sure that we can best prepare the acute care facility. But you have a whole different patient population, so how are you preparing for this? And maybe talk a little bit about the conversations you've had with your employees about how they can best prepare their patients for what is probably inevitable, but it really depends how we manage it and how we use our resources to support our patients.
Yeah. Great question. And I'd like to talk first about how the leadership team has been working at VNH in our preparations, and I'll ask Sara to actually speak to the work that has been happening with preparation of staff and working with our frontline clinicians on their interactions with patients and families. But so, as every member of the health system, our awareness has been heightened over these last several weeks, and we began with a tabletop exercise before we really knew much about what was happening in the communities to see where our strengths were, where we needed to focus, and very quickly got connected into Dartmouth-Hitchcock and all of the planning work that was happening here. We're also very fortunate to be members of our state associations and the National Association for Home Care and Hospice that have been guiding the work for home-based care providers, in addition to, of course, the guidelines coming from the CDC. So we're staying connected every single day in terms of leadership huddle and command center to make sure that we're staying current with the information and so that we can do the work that's needed to prepare our staff to work with patients and families as the situation evolves. And Sara and our entire leadership team really has been leading that effort, working with the group. So I'll ask Sara to talk a little bit about that.
So when we came together as a leadership team a few weeks ago to do a tabletop exercise, it was because we have had an emergency preparedness plan in place for a number of years, and we recognized that we were well prepared for the emergencies that happen often in this area, snowstorms, power outages, but we recognized that there was some opportunity to think about how do we sustain operations longer in a situation such as we are in right now. We set
Our guys are like the Postal Service.
Yes.
Rain, sleet,
Correct.
snow, hail.
Correct. Right.
The visiting nurses always show up.
Yes. And sometimes it's hard to ask our staff to not go because they want to. But we set basically 3 objectives at the beginning when we did our tabletop exercise, which have remained the same, which is our goal is to continue our operations while keeping our patients and staff safe, to coordinate our efforts with other members of the healthcare system and throughout the state and our community partners, which we have a unique opportunity to be connecting with each town, and to be thinking about how do we communicate constantly with our patients and with our staff so they don't feel that they're trying to figure out what to do, but rather they have direction in what to do. And so, as Johanna mentioned, we've really been guided by whatever available information and science there is from the state and from the CDC, and working hard to maintain continuity between what patients might be hearing in one setting with what they're hearing in the home setting, with a recognition that care in the home is different than care in the acute care setting. The exposures are different. The care setting is different.
You know, I bet the patients ask a significant number of questions of your healthcare providers when they see them. It's probably their only access outside of news and maybe social media, but a lot of your patients aren't very active on social media. I'm sure they ask your employees lots of questions about what they should do. What are you telling people to do?
So all of our recommendations would be consistent with any other recommendations that you would read, but like you're saying, some of it is just hearing it face to face. So we start with screening every patient, every visit, every time. And that is any of our providers that might go into the home. So it's our registered nurses, our LNAs, our home health aides, our personal care assistants, our therapists. They are screening every patient and their close contacts beforehand. So we're setting the stage of we want to be aware of if there's any potential exposure. And then when in the home, they are seeing us use appropriate PPE, as we always would have. If there is anybody that does have a cough but screens negative for travel or for exposure, we would put on a mask, as would be typically appropriate. And so then we are reinforcing what we would hope the behaviors would be in the home to keep people healthy, knowing that people still get sick. So thinking about frequent hand washing, disinfecting the high touch areas, and being aware of coughing into your elbow, all of those typical behaviors that we want people to be doing.
That people need to do in the home, not just out in public, especially if they're sharing their home. There is a question we received from a patient, one of our viewers, about their elderly father. So they moved their elderly father into their home. And you know, they're doing everything that they've been told to do. They're washing their hands, surfaces, sneezing and coughing into their elbow, social distancing as much as they can with a family of 5 under one roof. I get how difficult that is.
Tricky.
I can't get a social distance from my cat. He seems to want to sleep on my pillow every single night. But they're asking what else they should do to protect their elderly parent, and they're asking whether or not they should wear masks in the home. What's your guidance?
So the recommendation would be if there is nobody with a cough, that masks would not be advised in the home. It's not going to protect anything. If nobody has any symptoms and are not actively coughing, a mask is not going to help. Additionally, it's really important that we think about conserving those critical resources, like the protective equipment that keeps our healthcare providers safe. And so, as we've seen in the news outlets, the purchasing of masks by civilians has contributed to the shortages that we now have. And so we would not encourage the patients in the people in the home to be wearing masks.
Now, I know that there is probably a broad kind of regulatory environment, and there are a lot of compliance expectations. How do you actually balance quality and compliance processes when you have a public health crisis, which this is a public health crisis?
So I would start by saying the first thing we're working to do is really understand the impact from a regulatory perspective. And so we know that we have plans of care, we have physician orders that we need to carry out that are part of the requirements for us in home health and hospice care. But there will be times in situations like this where we cannot necessarily meet those orders. So we are tracking on that and understanding the impact, communicating with our providers if we need to change a plan based on availability of staff and resources, and that's really the first step. The next piece is working with our national organization who has been in communication with the administration and CMS to understand where our regulations we might have some latitude during these emergency situations so that we can continue to maximize the resource and potentially distribute that in a different way in terms of the types of visits we do and the number of visits we do so that people have what they need in their homes and in their communities, but we stay compliant with our regulatory requirements.
Yeah. It'll be interesting to see if they amend any of those regulatory requirements. We are seeing broadly people actually allowing critical access hospitals to care for more patients above the limit of 25 and keeping them longer, understanding that available beds may be a pressure point. We do have a question about an elderly patient. Her daughter asks that she needs to go see her primary care physician and is located in the hospital, and it's for something that seems kind of straightforward, but because of her age could be serious. This is the difficult decision point around ambulatory visits. At what point does somebody need to be closely monitored, because if they are not, they could end up in our emergency room. We absolutely don't want elderly people unnecessarily in our emergency room. So they say, is there any other way to not bring her to the hospital? Now I would say let's figure out a telehealth, but can they just call you and ask you to do a home visit? And I know there are a lot of regulations around this, so I'll let you take that one.
Yeah, so I'll ask Sara, who is our expert in eligibility requirements, to field that question.
Right. So under our current regulations and the way that our conditions of participation are written for the Medicare program, in order to receive a referral and see a patient, the patient has to meet a couple of criteria. Primarily one of them is that they have to be homebound, which means it's difficult for them to leave the home. We understand that there is a need to think about other ways to assess individuals in their homes right now. I mean, it has been one of the conversations at the national level, considering whether or not there's a way to relax that homebound status so that we could perform that sort of one-time check-in visit. At this point in time, we're not there, but our nurses do have the skill set to perform the same assessment that a nurse could do in an ambulatory clinic, and could absolutely serve as that conduit to help a physician or another advanced practice provider understand what the needs are. And so we're staying in contact with the national organization on this.
So really right now they probably need to reach out to their primary care provider to see if there could be some type of video visit or phone call to really answer questions so their elderly mother doesn't have to come into a facility if they're nervous about it. Many other questions. My elderly father has self-quarantined because he's fearful of getting sick. He won't let anyone come to his house except one of your staff who he adores. I used to come during these visits, but she's no longer invited. So, and she liked to do it because she wanted to make sure he understood the instructions and could follow them when he was on his own. And then she always got a kind of a sense of how he was doing in her visits. But since she can't attend personally, she can't really tell over the phone how he's doing. Is there any way for her to talk to the visiting nurse that is visiting him?
Absolutely. And that's actually an essential function of our case manager team that are doing these visits in the home. They coordinate with family members and, of course, the providers who are ordering care, but there are often other community partners that are providing services, and so it is an essential part of their work, and they were happy to talk with family members with permission, of course, from the patient to share information about that visit.
Yeah, that's great. Another question from a viewer. Many people across New Hampshire and Vermont are finding themselves at home. What can VNH do to support patients at home who are at risk for social isolation, especially during this time? I have to believe that we do have some elderly people who are living alone that are afraid of coming out. So talk a little bit about how you approach that. I have to believe that community partnerships are a really important part of that.
They are very important, and first and foremost, and Sara mentioned this already, but the continuity of our service is really important. So even if we're not able to do that face-to-face visit, ensuring that there is at least telephone contact, and we have other members of our team that are able to do that more regularly, including our volunteers. We have a number of volunteers who are able to reach out and make those connections with people so that they feel that they have a resource and an interaction with folks. One of the organizations that we also work closely with as an opportunity is the community parish nursing team. So again, they may be limiting those face-to-face visits, but it's another part of our workforce with clinical assessment skills who can reach out and have those telephone conversations and understand how people are doing.
Yeah. I think not everybody really appreciates the network of parish nurses that we have across the Upper Valley, and they're funded by some of the communities.
They are.
And they are available to check in on elderly people, especially if they're self-quarantined. Do people ask you about the specifics about self-quarantine? I think sometimes we say self-quarantine and they're not really sure what that means.
So we have been communicating the same information that we would find on the websites, specifically that if patients have chosen to not venture outside of their homes, that what they are doing is choosing to sort of self-isolate, and that they're restricting their contact with groups and with potentially with other in environments where there might be more potential for exposure. And so while we haven't gotten a lot of specific questions about that, what we are seeing is the patients who are choosing to do that, as that viewer's question alluded to. And we have a couple approaches that we are taking. So we aren't restricting visitors to patients' homes. We are not asking close contacts to stay away. We are screening all of our patients and all of their close contacts. So I think what we would encourage is education around that there is a balance between self-isolation and ensuring that there isn't complete social isolation. And we are really acutely aware of the risk in that. Our population is already at risk for that. And as we know that community centers are being asked to close down, that risk increases. And so if we do have patients who are feeling more apprehensive about visits or visitors, we actually are looking for ways to increase our phone contact with them that goes way beyond what we would typically be doing under normal operations, because we often are a point of contact for them during a day that they otherwise wouldn't receive. We're also working to stay connected to the communities and offer opportunities for patients that they may not be aware of. So as community centers close, what are the alternatives through the community center that they could tap into to make sure they still have food, they have their meals, they have somebody who is keeping an eye on them.
We have one last question. Many people are concerned about their regularly scheduled appointments and are considering canceling them. Do you ever have people that cancel your appointments into their home?
We are seeing that this week.
That's increasing.
Yes, and so we are, education is key. And so we worry first that is being done because the patients don't quite understand that the reason we screen every time is not because it's because we were always looking and staying vigilant for the potential for there being any exposure, but that in doing that is how we keep them safe and how we keep our staff safe. So the patients who do cancel will get a follow-up phone call inquiring into how they're feeling, how they're doing, how their health condition is first, and then providing additional education about what we know in terms of spread and contact and exposure right now, and help to reassure them, because our goal would be to continue to see them. We are working towards completely normal operations.
Your team is an incredibly effective resource to actually keep elderly people healthy and at home. And I have to believe that there are people that, out of lack of understanding, may actually be foregoing ongoing visits, renewing their medications, getting the right foods, so they can continue to stay healthy. So anyway, so I think it's kind of time to wrap up. I want to remind people that we have a tremendous amount of information on our website, dh.org, and there is a hotline that you can call if you have any questions, and it's 603-650-1818. Thank you, everybody, for listening to Facebook Live this St. Patrick's Day.
Thank you.